True. Well, hello, everyone. Thank you for being here. Anytime school-connected humans gather in a space when the students are about, I just feel immensely grateful and honored. And so thank you for showing up and for being here. I am I'll give you the outline of kind of where we're headed today during this hour together. Please know that if at any point you have a question, I'm happy to receive that in the chat or by raising your hand. This doesn't have to be formal, and I have some things that I'd like to get through. So if we start to rabbit trail, I'll bring us back gently as well. So my name is Jill. I use she and her pronouns. I work for the Oregon Health Authority in the Health Systems Division, which is the behavioral health side of the agency. I live in Scio, Oregon. Quick show of hands. Who knows where Scio is? Jennifer and Taylor. Good. Excellent. You two received 10 points. So congrats on that. Scio's in rural Lynn County. I come to this work for a variety of reasons. I like to tell people I do this work with my head and my heart, that I so far like figuring out the system and figuring out how to make a system make sense on the ground. And this work is heart work for me. I am a person who, I spent 10 years as a school counselor in a variety, in 3 different school settings, and did restorative justice with juvenile justice before that. I am a person who, I have a daughter and a brother who are suicide attempt survivors. And I'm a person who's had 3 seasons in my life where my brain thought about suicide and I needed to be able to get extra resources and help. And so that all has kind of piled together in a beautiful puzzle of being able to do this work of suicide prevention as a real human and not a robot. I never intended to become a government employee, and here I am. And turns out I kind of like it. It's mostly really good. So I'm coming here today to talk to you about kind of a kind of level setting when we're talking about youth suicide in Oregon, and then to make sure that you all hear about the pretty remarkable resources that Oregon has available to you all and to your schools and to your communities. And then to see what questions kind of are batting around for you or ruminating for you. And so again, if you are just joining, feel free to put questions in the chat if they come up, or if there's a burning question, you can also raise your hand, raise your Zoom hand or your real hand, and we'll kind of go from there. I want to start with a bit of a disclaimer. I work in the world of youth suicide prevention every day, all day. This is my 100% of my conversations are about youth suicide and how to prevent it. And that's not normal for most humans. You all signed up for this gathering, and so I imagine you knew this was our topic this morning, but it does not matter how long I'm in this field or how long I'm in this job. There are moments where it just kind of bubbles up and hits me because we're talking about youth suicide and how to prevent it. And so I just want to name that if your human heart experiences activation or feelings, I would encourage you to feel those feelings because it's not normal to try to stuff those things down. I would encourage you, for me, it's helpful to have to move my shoulders and my body a bit, even where I'm sitting. It's helpful for me to find my feet planted on the ground, take a deep breath. And for me, it's helpful to take a drink of water that signals some somewhere in my brain that I am uncomfortable and still safe. So those are the things that work for me. Find the things that work for you. And the truth of the matter is, you are not stuck here. The rule of 2 feet. If this is not a space, if it's a space that you thought you would be able to be in today, and it turns out it's not, that is just fine. And I am just going to try to contain my excitement about Brooke Cottle joining the room. Hi, Brooke. Okay. Okay. The world of youth suicide prevention in Oregon is one where there's room for great growth and room for great hope. You may have heard statistics over the course of the last couple of years that while Oregon remains above the national average for youth suicide, we had a tiny little blip in 2010 where we ducked under the national average for youth suicide rates. But since the charts started to be charted, Oregon has been above the national average for youth suicide. And the last 3 years of finalized data, 2019, 2020, and 2021, all show decreases in youth suicide. That's different than the national average. If you wanted to find your heart emoji or clap emoji or celebration emoji, you could. This would be an appropriate time to do that. That some of the work that we have poured into and been serious about and anchored to has shown a difference, and that is not true for the nation. And it doesn't make any sense. We all thought in COVID, myself included, that we would have a different narrative to tell. So that is a true story. Another true story in that same data set is that those decreases in youth suicide deaths only show up for non-Hispanic white students. That is incredibly clear in the data charts from 2018, 2019, 2020, and 2021. We're about ready to get our finalized data for 2022, so we'll be able to kind of add to the data picture. But what we know is that we have a mandate as a state to do better for all kids, that something about what we're doing is having a system-wide impact, and it's not an equitable impact across the board. And so we have, I'm going to talk generally about our programming, and then also talk about kind of some culturally specific pieces that we're leaning very hard into as we take our next right step, which is one of our favorite things to say in our field, is that what's the next right step for us to take. And so I'm hoping that as you listen to kind of the resources and the presentation, that you're thinking, okay, what's my next right step? Not, holy crap, I have so much to do, there's no way I'm going to get all of this done. Because while we can do anything, we cannot do everything. And so asking you to think about what's the next right step in your lens and in your building and in your systems, and maybe in your home, all of those pieces as we go. I'm going to start with a story that we tell often in the world of prevention. A story of three sisters. Three sisters were walking by a river that led to a dangerous waterfall. And on their walk, they heard a cry from the river. A young person was swept up in the current and headed towards the dangerous waterfall's edge. One sister jumped in, rescued the young person, brought them to the shore, did CPR, brought them to the hospital, called the parents, the life was saved, did the crisis response triage work. One sister mobilized the community, started teaching water safety techniques and installing watchtowers and making sure everybody knew CPR. And the third sister walked upstream to see why the young person fell in the river in the first place. I used to think, when I heard that story, it was like, because we were saying prevention is the most important thing, that it was the third sister who really got it. I now think that what that story tells us is that all three are important, that in the world of suicide prevention, and I would give most prevention of terrible outcomes, that all three of those things, we need people stationed and attuned to all three of those areas. And in our world, we also need to have care in a post-vention space in the waterfall analogy as well. And so the other thing I want you to think about as you hear about some of the resources and things that are available is that you are not all of those. You can't be three sisters. You can't be three people. You can't hold all of the roles that there are to hold. But might you be able to help identify where those sisters are and what sort of equipping that they might need to do their piece of the puzzle really, really well. I will also note that our suicide prevention programming is not therapy focused. That therapy is an important part of a wellness picture for a lot of people. That therapy works for some people sometimes, and that it's a really important puzzle piece, and it's not the focus of our programming. It's not the only focus of our programming. And so I think we sometimes get stuck in the, like, we don't have enough therapists, I can't get kids into therapy as the conversation when it comes to suicide prevention. And I'm asking us to take a Three Sisters view of that piece of that conversation, in that we know that a whole bunch of things are protective when we talk about suicide prevention. And therapy can be a really important part of the puzzle. Having therapists that know how to treat suicide when it shows up in their offices, in clients' hearts and minds, is important. It's one piece of the puzzle. It's not the focus of all of the whole picture. And so just encouraging us as a field and as people who care about people who think about suicide, that we don't let ourselves get sucked into we don't have enough therapists vortex, because it's true, we don't have enough therapists. We need more therapists. We need therapists who know what they're doing, and we need therapists who can meet kids and students where they're at in their cultures and in their families. That is true, and it's not the only piece of the puzzle, it's a piece of the puzzle. I'm going to pause there. Is anything rattling in anyone's brain or pinging in someone's brain that you want to add before I launch in? I was in this training this week where the facilitators had purposed to count to 30 every time they asked for a feedback. Then they counted to 30. And I was like, oh dear God, that is the longest amount of time to just sit in an online space staring at, like, made me want to think of a thing, which I think maybe was the goal. Okay. Oh, I had one more level set. One more. We are not therapy focused in our programming. If someone just asked me what we are laser focused on, it's connection and belongingness. So anything that falls into the category of increasing a person's connection to culture, to other humans, to themselves, to nature, and in particularly a connection in a way that fosters belongingness. That is the best suicide prevention there is. It's not like fluffy, like, I don't know, it's not the floof on top. It's like the core. It's the most important suicide prevention there is. And so our field has spends a lot of time training people about what signs to look for, and warning signs, and how to intervene when you see those warning signs. And that's all really important. And if a young person or a not young person has a sense of connection and belongingness, that protective factor is much louder and stronger than any risk factor that you could throw at a young person. And so just naming that anything that your programs or your systems or your household or your school is doing to promote connection and belongingness is suicide prevention. And it's not fluff, it's like the best. Okay. Amber says, we were just talking about the power of connection and belonging in our DEI conversation before lunch and how much those factors promote well-being. Yeah. and sleep. That's the other thing that the train that I can get on really quickly about suicide prevention and sleep. Okay. In Oregon, I hope you have seen this. This is what we lovingly call the Big River. Raise your hand if you have heard of the Big River and or have seen the flyer that I just put in the chat. And you can give a thumbs up if you're not on video as well. Okay. So don't get overwhelmed. First of all, to be clear, this map of programming for suicide prevention programming in Oregon is not meant, it's not a list of trainings that you need to take for you. It is a Three Sisters approach of saying, way upstream, what do we have? What do we need to do to train the people to recognize warning signs and risk factors? What does it look like to intervene and ask directly about suicide with a young person? What does it look like to hold space with that young person and safety plan with that young person? What does it mean to treat suicidality and thoughts of suicide and behaviors? And then what does it look like to have a community that's trained and ready to respond in a post-vention after a youth suicide has occurred all along. And so the next one I'm going to put in the chat is that is the Big River by provider role for schools. So that second one is the same programming that you see in the big flyer, but broken out by who would it make the most sense, which roles does it make sense to ask to take which trainings in the Big River, and then what the cadence of retraining might look like. Priscilla? No worries. Okay. So those are kind of the bread and butter of our suicide prevention programming that we have available for around the state. Micah mentioned that in, it was a survey or a conversation that a reoccurring theme that Micah heard from you all was around not feeling like you have access to training and being able to know how to training around suicide prevention. And so I'm going to pause my yakking at you for a second and ask in particular, could you describe the kind of training that you see the gap in? Like, is it training for basic training in suicide prevention, how to recognize signs and symptoms? Is it training for students? Is it training for your behavioral health therapists in your school-based health centers? Where are you noticing the disconnect?
And just to add on, so that was the #1 identified thing in that Garrett Lee Smith survey that went out to all sites about a year ago. And it was around being able to have that whole continuum of supports for students around, training was the top thing. Great question, Jill.
Nancy, go for it.
Hi, I'm Nancy Sink. Sorry, I was eating. I had my camera off and I didn't type in the chat. I'm the MD medical director here at OHC Benson Health Center in Portland, Oregon. And we have noticed that us as providers feel a little bit not necessarily like completely comfortable, like we shouldn't be comfortable, right? It's suicide training and positives. And when we get a positive, we're always a little bit unsure about our threshold to get in our LCSW. We work for OHSU, she works for PPS. The minute we have her talk to a student and she mentions the word suicide or screening, she has to call the parents. And we don't until it kind of reaches a level. And so we struggle a little bit with where that bar should be. And we also struggle a bit with the patients that are chronically suicidal, just like no matter what we do, no matter what meds we try or we do, or we send them to therapy, whatever we do, they still come back with suicidal ideation. And so we've actually, thanks to Micah and team, asked for like an individualized training with just our professionals here with a child psychiatrist, because we felt like none of the trainings really fit and we really only have 3 to 4 hours. So that's where we identified the gap for our personal school-based health center. Like the other trainings look great, but like we're providers and we have to take off from patient care, and it's really hard to get anything. And I mean, I managed to block my schedule from patients right now to even attend this meeting. So it's just very, very difficult. So thanks for listening.
No, thank you. Thank you very much. So I'm going to say back what I think I heard you say, just to make sure I don't rattle on too long in an irrelevant direction, that for you all, it's the being able to screen for suicide is okay, but not knowing then what's the threshold to be able to refer to the social worker, who then has to call the parent, because that moves it into a whole nother category. And wanting to be better equipped and kind of being able to gauge what level of risk and that type of thing are we talking about here. And the time available for trainings is something like 3 to 4 hours versus the 7 that is what we have now. And then the second is chronic suicidality in students and cases. Okay. So the first one, the training that we have for primary care settings is called Youth Safe Primary Care. It is specific for non-behavioral health clinicians. It is 7 hours long. And so I hear you that like cute, but we can't take that much time off. The one thing that I will say just in advocating for it is that the Youth Safe Primary Care module safety planning piece is excellent. It's one of the best I've seen. And so it might end up being worth having some people trained in it and then being able to talk through how to use the safety plan and that type of thing. And so I wonder about kind of a tiered approach to training instead of the whole team having to go to a training like that. The other piece that I'll say there is that I am of the opinion, and I will get into a debate with whomever would like to around what roles are most appropriate to have a conversation about suicide risk and basic safety planning. That I think school counselors should do that. That I think nurses should be able to do that. That I think that there should be more of us being able to have a non-crisis conversation, knowing that 20 to 30% of our young people have thoughts of suicide, that shouldn't be a crisis moment. That should be like, okay, well, sounds like your brain's starting to think about suicide. Here's what that looks like. Here's how to keep yourself safe. And then here's when you need to ask, like, these are the indicators that you need to ask for more help. And so to check on those. And if then that reaches the threshold of the behavioral health referral, then parents do need to be looped in. Then that's the right order. But one of the most protective things that can happen to a young person is being able to say, and any of us too, young people or older people, being able to say like, yeah, my brain's thinking about suicide right now. I don't think I'm in crisis, but it's starting to chirp. And so I need to start looking at it. How protective is that to be able to have that conversation and normalize it and name it, that most humans at some point in their life, their brain starts chirping in that direction. And what if we could recognize it, have a conversation about what safety looks like, and understand when it needs to escalate. So that is a rant on that end. The chronic suicidality piece, somebody, Ben, you mentioned, where are you, Ben? Oh, you're down there. How do you say your last name?
Very carefully.
Yeah.
DiGiulio.
DiGiulio. You know, I just like a name like Jill Baker is so boring. There's nothing, people can remember it, but it's just like yawn. That CAMS is one of the advanced training courses that we have. CAMS is actually something that you can just buy the workbook and use. So you can take the course, it's good. But you also can spend $35 on the workbook, and it outlines the process and has the forms in it. And in fact, if you take the course, they require you to get the workbook because the workbook is the meat of it anyway. So that's the other piece that I would say if you're looking for some backfills piece. CAMS is Collaborative Assessment and Management of Suicidality. So it lays on top of any sort of like theoretical orientation for therapists. So it doesn't matter what kind of therapist you are or counselor that you are, CAMS sits on top of it and is a suicide specific intervention. So so it's not meant, it's meant to ask about suicide each time, has some measures to be able to gauge where the student's thought process around suicide is, and then be able to build interventions tied to that. So so CAMS is one that you can go all in and get lots of training and support around. There's consultation calls and a big community of people that are trained in CAMS, or you can buy the book and read it. That's how I got started in CAMS, is I bought the book, the workbook, and then I took the course later because I was like, oh, I would like to ask 700 questions about this. So the other piece of in that advance in the Big River.
I think Jill froze for us.
Oh, okay, I'm glad you said that. I thought it was me.
All of us. Taylor, are you and Jill at a place where you can just finish your sentences?
Yeah, no, we're not at all. But I love that, you know, she paused mid-sentence. This does happen. I work with Jill really regularly, and because she mentioned she lives in Scioto, which is rural Lynn County, video off is often the way to go in these larger meetings. And sometimes even everybody else needs to turn their video off too, but we'll see when Jill returns with her internet, what status she's at. I do just want to draw attention. I dropped a link in the chat to the CAMS Care training book that Jill mentioned. I'm also going to drop a link for AOCMHP's website that they oversee CAMS training as well for the state of Oregon. So if you're interested in doing some training outside of the CAMS booklet and you want a really structured process, AOCMHP might be a good resource. But when you talk about what Jill is talking about, that time commitment, it is a big time commitment. So I just want to make sure that I mentioned that as well, since Jill fell off for a second here. But hopefully we'll be back momentarily.
In Jill's absence, while we wait for her to hopefully rejoin, are there any things coming to mind for folks that they would like to chat about or share about, knowing that they won't have Jill's brilliant viewpoint back on it?
I have a question. Maybe I could just ask Micah. Nancy, the project you were mentioning, is that, Micah, one of the ones we're funding through the additional? Okay. Very cool, very cool. That pinged for me, but I just wanted to make sure that that was something that, so that's one of our goals with Garrett Lee Smith, is to get more suicide prevention work happening in SBHCs as well, but didn't have a lot of funding to do that work. So it's a learning experience for us. And as we apply for the next session of Garrett Lee Smith funding, which should be this spring, because our grant runs out in June, it's informative. And I see Jill is back with us.
Yeah, and for the OHSU training, I think it really was, how can we creatively get to some of those barriers that Nancy spoke to, especially when folks have already done some level of training across the staff, and wanting to see if there was some invested time. Jill Baker, I remember your name. Are you back? Your Jan name?
I am here on my phone. I don't know what's happening with my SIO's irritated, I guess, with internet, seems like. Where did I stop besides this phase?
You were about to tell us one more thing about the Big River.
Okay, yes. Another option on the Big River for training is around DBT, dialectical behavior therapy. We support DBT skills and DBT suicide prevention. And those pieces, when I've taken those trainings in the past, they have pieces that you can kind of grab and plug, not to fidelity of DBT, but you can grab and plug in spaces. And they're just really, really good at kind of distress tolerance and being able to work through skills of being able to talk through hard things that are happening and that type of thing, and particularly with families. So if they're high conflict high family conflict, and that's contributing to suicidality, that is, there's some good tools there in that training to take. And as far as chronic suicidality, DBT is the standard, and it's really hard to get into a DBT program. So both things can be true, that it is the best, it's the most effective, and it's not as widely available around the state. But plugging in pieces of CAMS and DBT into practices is better than nothing. And so, and in particular, the groups part of DBT for school-based health centers, I keep wanting to see if I can get some interested people in piloting that. What it looked like to be able to have, CAMS trained social workers or CAMS trained. Stephanie runs a DBT group in their school-based health center. Will you unmute, Stephanie, and say more about how that works for you? Because I think it's good juice there.
Yes, I'll try to start my video too. Hi. Yeah, so I work, right now I split my time between Oregon City High School and Clackamas High School, but I've been at Oregon City High School for 5 years, and I started running a DBT group there 4.5 years ago. So every year I run a DBT group, and it's during school, so it's an hour per week, and I have an adolescent skills training manual for DBT that I've been trained in and have periodically done kind of retrainings on DBT. But yeah, then I just run one group a week.
Yeah. Is that connected to individual therapy at all? Or you just have your group and then they go to all their own?
The way we have it set up right now is that they're also individual therapy clients through the SBHC. We've got multiple therapists that work at Oregon City High School, so we've got a lot of pools to draw from, which is really fortunate. Sometimes we can do groups for people who are just on the primary care side, and we'll kind of bill it as a BHC group. And sometimes we've had mixed groups, but usually they have to already be clients of the SBHC. They have to sign the consents and everything.
Yeah, that makes sense. So the question's still on the table. What sort of training gaps do others see? I have a couple other directions I want to head, but I wanted to leave space for that question to be able to. Have folks tried to get registered for the advanced skills? So that would be CBT, suicide prevention, DBT, suicide prevention and skills, CAMS, and attachment-based family therapy. I think they're the 4 that we have, that we purchase seats for, and they're free for folks that are around the state. And they go out usually through the Association of Community Mental Health Programs, AOCMHP. And so I don't know if we've done a great job of advertising to you all. And so that is one question I have, is that have folks seen the availability of those? Thank you, Taylor. Okay. Another thing I'd like to plug is thinking about where your CBT trauma, that is also available. It's not, I sometimes forget about it because it's not paid through our program, but it is OHA sponsored. Jesse.
One of the questions I have about the trainings is, I work on the Zero Suicide Initiative as the only case manager right now for Clackamas County, working with youth, and there's and I'm a QMHA, not a QMHP, and so there's a line there about what I can and can't be trained in based on that, and so I guess I'm interested in trying to figure out what would be, and I hear you when you would, and had exposure as under the rubric of ICTS to DBT work and got some training in that regard. But stuff that is appropriate and consistent with the role as a QMHA that would bolster my capacity to do the daily grind of talking with only, as you said, suicidal folks all day long, every day.
Yeah. I would recommend Youth Save for behavioral health providers. That is available for QMHA level. It goes through, so it's 9 hours total, 7 hours with an instructor, broken up over 2 days. And then there's an hour of homework, pre-work. And then after the training, they ask you to integrate it into your system. So like where, where does it fit? How can you get support for implementing it from your managers and that type of thing. We just changed contractors for the Youth Save for behavioral health. So Youth Save Primary Care is still Oregon Pediatric Society, but Youth Save for behavioral health is now under the House of REAP Incorporated. So I'll make sure and get that. And that link is not on any of our flyers yet. Like it's hot off the presses. And so I will get that link and make sure Micah sends it out to you all as well. The goal, there's lots of gold to that program. It was developed by brilliant humans. There's an equity focus beautifully woven throughout. It's now being put out by a Black-led, Black-founded organization in REAP. And the safety plan part of the Youth Save as a school counselor, it's just so good that it's strength-based, it's collaborative. It talks about like what are the people and the practices you need to be well. And so it doesn't, that safety plan, I'll go ahead and attach that, Micah, to send out also. That safety plan itself is a tool that I would encourage folks to use with students, that you have the opportunity, because you can send it home and you can check back in on it. It's like as a check-in to say, here are the things that you said you wanted to lean into and strengthen in your life. How's that going? It's really, really good.
And Deshaun and Monica actually led a Youth Save for school-based health center folks, I guess probably a year and a half ago at this point, are phenomenal. And Jill, I believe they're sort of the main trainers that they're sticking around as trainers with contract. Yeah.
Yes. And if there's a big enough interest, I can pay for another training for school-based health centers if that is something that you all are interested in. I would love a commitment to show up. No judgment. But paying for one of those is money well spent in this for you all as providers, and want to make sure that it's something that that folks are able to actually take advantage of. It's so good. Hey. The last thing that I have on my prepared list is that each of you, I hope, knows that your school districts have an Addie's Act suicide prevention plan, that every school district in Oregon needs to have a policy and a plan for suicide prevention, intervention, and postvention. And school-based health centers have should be pointed to in those plans, so that there should be some way of knowing. So it's not a requirement. That's not in legislation. It's just like, this is what my brain thinks should happen. That wouldn't it be lovely for school districts to know how their school-based health centers are involved in their suicide, both prevention and intervention, and particularly in a postvention response after a suicide death. And so if you would, if you don't yet know what your school district that you're associated with, what their Addie's Act plan is, it's also supposed to legislatively be on their website. So maybe try to go find it. If you're struggling to find it, I can help link you to the human that is tasked with that work in your district. And then see if you can get at the table for when they're looking at it and updating it, and thinking about suicide prevention, intervention, and postvention for students around the state. That is what I had prepared. It is not a whole hour, but I think that's okay. What other questions do folks have?
I'm going to ask a question, even though I know there's probably people with other questions. Do you speak a little bit here? I sent out the like suicide prevention and intervention for Latinx communities to
Thank you.
email list. And I know the work with REAP got talked about a little bit, but just really naming, I mean, the disparity that you named around youth suicide going on for the state, but not for students of color. Like, I'd love to hear more about that and how SBHC specifically can get connected to that work.
Yes, thank you for bringing that back up. My computer glitching threw me off on that. So one of the strategies that we're trying to lean harder into is around culturally specific suicide prevention work. Our field, the field of suicide prevention, is pretty new in the behavioral health world, and it's historically been a pretty white dominated field. And so we have, the whole field has a long way to go, and Oregon has is not an exception to that. So a couple of the strategies that we've tried to incorporate are, what are the adaptations to the current trainings that we can build in to say, to thoughtfully consider culturally specific adaptations and linguistic variation, and see which of the Big River trainings we can make available in Spanish for parents and students and community members. And so there are a couple of things that have already bore fruit in those areas. One is around suicide prevention considerations in Latinx communities. So Dr. Ruth Zuniga, who's the executive director and co-founder of Raíces de Bienestar, developed this course for English-speaking providers to just increase cultural competency around the field specifically of suicide prevention for Latinx people. And that course is free of charge. It's 3 hours. It's online, on demand. And so it's like, I couldn't take it all in one setting because it's 3 hours of an online video. But it's so good. So loop back to it. We had, Taylor put the link in the chat. Thank you, Taylor. It's been available for a little over a month. And we've had about 400 providers take the training. So we know that it's needed in our field, and it's so good. Plus, Dr. Zuniga is just like who I want to be when I grow up. Her presence is so good, and she's so smart. We have leaned into tribal specific train the trainers for several of the Big River programs as well. So Sources of Strength we have a tribal specific train the trainer happening she did speak at the Oregon Suicide Prevention Conference in Hood River. Yeah. And so that's a collaboration with Oregon, tribes in Oregon, Washington, and Idaho to come together for the Train the Trainer. We have tribal specific QPR, Question, Persuade, Refer, Mental Health First Aid, and Connect Postvention. Those 4 of the Big River programs. And then our specific work for Black youth suicide prevention was really launched in the middle of 2023. That work is, there's a group of 10 African-American leaders, brilliant humans. Deshaun Williams is also on that team. He's the youth safe trainer that we talked about earlier in this meeting. They're launching a Black youth suicide prevention statewide coalition. They're looking for Black youth leaders ages 14 to 21. And so if you've got Black, African, or African-American youth that you would want that are interested in mental health and mental wellness and making a difference in the state, there is a information session called a virtual youth mixer. Which is way hipper than information session, on Monday. And so the link to that is included in the, Taylor, you put the children's team newsletter in the chat. the Mixer link is included in that as well. That opportunity, so if you do have a young person, a Black young person that you're thinking of, they're recruiting youth leaders that will get paid $75 an hour between 5 and 7 hours a month to participate on that Youth Leadership Council. And so it's a paid opportunity if they are accepted as a youth leader as well. Oregon just got a chunk of money to do better for Spanish speaking and Latin communities in the world of suicide prevention. And so that work, the work of trying to increase Spanish availability and culturally specific availability across the training programs will start showing up soon. And as we work to get that into contracts. Thank you, Micah, for helping me remember that. I skipped over it. I said it was the most important thing and then skipped over it.
Thanks, Jill.
Yeah. I'm on my phone, so there's 23 chats I haven't read. Is there a chat I missed?
I think Taylor has really been responding to all the things and dropping. They're mostly Taylor drop-in links, and I will consolidate these all into one document to send out some brief notes too.
I see a couple of folks wanting to connect directly. Taylor, will you put my email address in the chat also? Can you spam the chat again with my email? I'm happy to have a conversation. This is my bread and butter. Youth suicide prevention is what I do, and wanting to get be as supportive as we possibly can. We have funds that we have a responsive team and creativity, and we're in it. So if there's a thing that we can do to make the system better, let's do that, huh?
Now do people have questions since I took the last question spot?
If not, we're going to awkwardly count to 30. All right. Thank you for being champions and superheroes. Be in touch. Let us know what you need. Hug your babies. Thank you so much for being here.
Yeah, thank you all so much. And Jill and Taylor, thank you for taking the time to talk us through this. And for SBHC folks, like, this was a really big turnout in a really busy week for this topic, which is like, there's more things, there's so much more. And I think like if you all have specific requests to anyone in the state program office around this too, like always reach out and let us know. I think we're always trying to find that balance of like what support. And I also know like a lot of you all are really involved in your school or county plans and initiatives and Addie's Act. So like if there's anything we can do to help facilitate those connections across SBHCs, given everyone's capacity, like let us know. I think this is important, and we're here to support in whatever way that looks like. So you know where to find us. Thank you all.